And so I show the technique, the examination technique for the ulnar collateral ligament of the thumb. We place the transducer here and on coronal plane, and then I'm flexing and extending the interphalangeal joint of the thumb now, and we are able to identify the aponeurosis and to distinguish it from the underlying ligament. This technique is very, very helpful. I recommend it because it increases the confidence in the diagnosis of a sternal lesion, of course. 5 minutes and more, and we move to nerves just to discuss the most important one, the median nerve. And we addressed the carpal tunnel before, and this is the carpal tunnel. You see during the dissection, the superficial tissues were removed, and you see the tendons as they diverge distal to the carpal tunnel. This is the position of the retinaculum, and after removal of the retinaculum, you see the median nerve and its divisional branches. When you examine the median nerve at the level of the carpal tunnel, it's important to place the transducer correctly over the bone landmarks. And we have to consider 2 main levels of examination, one, the proximal carpal tunnel and the distal carpal tunnel. And the proximal carpal tunnel is indicated by the tubercle of the scaphoid on one side and the pisiform on the other side. These are rounded bones, as you can see here, and can be easily recognized sonographically. On the other hand, more distally, the carpal tunnel is delimited between the tubercle of trapezium and the hook of the hamate, and these are pointed structures, as you can see here. Therefore, when you place the transducer, the first thing to do is to ensure that the transducer is located at first over the scaphoid and the pisiform, and then over the trapezium and the hook of the hamate. These are cadaveric cuts in which you see the bones and the tendons and the position of the median nerve. I show the median nerve starting at the level of the forearm, and you see a structure located between the flexor digitorum superficialis and the flexor digitorum profundus. This is the median nerve. You see the fascicles in the median nerve, and when we follow the median nerve distally, we see that the nerve, of course, is alongside the flexor digitorum superficialis. This is the nerve. Then it passes between the flexor digitorum superficialis and the flexor carpi radialis. This is the palmaris longus. These are the fascicles of the median nerve. Then the median nerve becomes a superficial structure, and now we are at the level of the tunnel, of the carpal tunnel. I select the lower frequency probe just to have a wider field of view, and and when we are at the carpal tunnel level, remember to place one edge of the transducer over the scaphoid and the other edge of the pisiform. This is the carpal tunnel level. This is the retinaculum. This is the median nerve. These are the flexor tendons. More distally, this is the trapezium. The trapezium is flat. This is the typical site of osteophytes in cases of degenerative osteoarthritis of the trapezium metacarpal joint. And on the other side, we see the hook of the hamate. This is the position of the retinaculum, which at the level of the distal tunnel is a little bit thicker, and this is the median nerve. Therefore, remember these 2 levels: distal carpal tunnel, proximal carpal tunnel. And the nerve can be easily recognized as a superficial structure formed by many fascicles. And lastly, just to show you how far ultrasound is going, A secondary branch of the median nerve, the palmar cutaneous branch. The median nerve sends a very small branch formed by one fascicle only at the level of the distal third of the forearm. And this very small nerve courses alongside the median nerve, then it pierces the retinaculum to move towards the flexor carpi radialis. This is what you can see. This is the median nerve, and this is the fascicles. The fascicle related to the palmar cutaneous branch of the median nerve. This is a structure, a very, very, very small structure, but is also a very important structure because it is one of the causes for persistent pain in this area after carpal tunnel release, because the surgeon, when opened the retinaculum, cut the palmar cutaneous branch, especially if the approach is too radial, if the surgical incision is too radial in position. And this is the final demonstration. I will select the highest frequency transducer, of course, to demonstrate the palmar cutaneous branch of the median nerve. We place the transducer at first over the median nerve at the distal forearm. This is the median nerve. Look at the radial fascicles. Look at this fascicle, and then you see these fascicles. This fascicle as it pierces the retinaculum here, now is deep, now is superficial to the retinaculum, to supply the skin over the proximal palmar crease. The nerve is a very small structure. Let me measure it. And in cases of an injury, you will see a scarring tissue enveloping the nerve, or you can see an neuroma of this very small structure of 0.3 millimeter inside, but very important from the clinical point of view. So this was the last structure to see. Thank you very much for your attention.